thank you for giving me this opportunity. And without wasting time, I will start sharing my screen. So I'm going to share an experience about durvalumab in extensive stage small cell lung cancer. There was a patient, a 35-year-old gentleman with no comorbidities who presented in June 2020 with complaint of hoarseness of voice. He had a smoking history of 20 pack years. He had already visited an ENT who diagnosed him having vocal cord palsy. He had already underwent a CT scan of the brain, head and neck, and chest. The CT chest was showing some mild enhancing soft tissue thickening with fibrosis in the left apical segment, multiple enlarged conglomerated necrotic lymph node in the left hilar, paratracheal, and the paraesophageal region, and there was aortopulmonary window nodal mass compressing the left pulmonary artery. Based on the CT scan, patient was outside treated with anti-tuberculous drugs, and his condition worsened over the next 1 month. Patient also developed an episode of seizure somewhere in September and was started on anti-epileptic drugs. MRI brain was done, which showed around 2 by 2 centimeter enhancing intraaxial lesion in the right temporal lobe with mild surrounding edema without any mass effect. There was also multiple sub-centimeter sized lesions in bilateral temporal and left frontoparietal occipital lobes. A CT thorax was done in October 20, where there was a space-occupying lesion seen in the left upper lobe with mediastinal extension and encasing the left pulmonary artery. There were multiple mediastinal lymph nodes and also consolidation in the left upper lobe. So this is the CT image of the brain lesion on PET images showing a left hilar mass, and patient underwent a biopsy and histopathology examination and IHC were done, which were showing it to be a small cell neuroendocrine carcinoma. His PD-L1 score was 3 to 4%. So the final diagnosis of extensive stage small cell lung cancer with brain metastasis was made. So what could have been the next step? Brain radiotherapy followed by systemic therapy, directly chemotherapy, or chemo-immunotherapy. So as per the guidelines, and what about treating brain mets in extensive stage lung cancer? So there was an article in this Radiation Therapy and Oncology Journal in August 2020, where there were following key conclusions made from the study that in asymptomatic patients, most of the panelists preferred giving chemotherapy as first line option. In asymptomatic patients with limited volume brain metastasis, a higher preference was chemotherapy without whole brain RT was made. Those patients who are symptomatic, in those patients, whole brain RT was given priority, and it was then followed by chemotherapy. And in symptomatic patients with limited extent of brain metastasis, some expert also chose stereotactic radiotherapy as an alternative to whole brain RT. This patient, as we know, was having seizure. He was symptomatic for the brain metastatic lesion. Again, the NCCN guideline for the extensive stage small cell lung cancer also classifies patients with brain mets into asymptomatic and symptomatic, and asymptomatic, they also suggest that may administer systemic therapy before brain RT after completion of induction systemic therapy. And in symptomatic patient, brain radiotherapy takes the priority. As we all know that chemotherapy traditionally platinum-based doublet, mainly etoposide platinum, has been given in various trials, and most of the studies with this regime show the overall survival being in the range of somewhere 9 to 11 months. So this patient was started on radiotherapy because he was symptomatic, and also he was started on first cycle of EP, that is etoposide platinum combination. As per the recent guidelines, which we all know that there are two molecules, two checkpoint inhibitors, one is atezolizumab and other is durvalumab. Both are approved in combination with the platinum doublet chemotherapy in extensive stage lung cancer. And this is the NCCN guideline suggesting the same thing. So the patient was discussed with this option was given, and first cycle we started off with just chemotherapy, and from second cycle patient was willing for taking durvalumab, and hence durvalumab was added from the second cycle of chemotherapy, and it was given in the dose of 1500 milligram every 3 weekly for the first 3 cycles, and then it was scheduled to be given monthly once. So as we all know that there is a role of immunotherapy in small cell lung cancer, we have 2 checkpoint inhibitors approved. So chemotherapy usually it induces tumor cell killing and induces tumor antigen release and exposures to the immune system. PD-L1 overexpression leads to immune cell invasion and T cell inhibition. So what does PD-1 and PD-L1 do? We all know that it restores the tumor-specific T-cell immunity by neutralizing the friendship between the tumor cell and the T-cells, and hence the T-cells are able to identify the enemy, that is the tumor cell, and able to kill the tumor cells. So this was a CASPIAN study. It was a phase 3 randomized control study. Patients with a good performance status and treatment naive patients with extensive stage lung cancer, small cell lung cancer were included in the trial. Patients with asymptomatic or treated and stable brain mets were also permitted in this trial. And there were 3 arms: durvalumab plus an investigational drug along with EP. There was another arm, durvalumab plus platinum doublet, and which was compared with EP only. When durvalumab was given, there were only 4 cycles permitted, while in the EP chemotherapy only arm, up to 6 cycles of chemotherapy were allowed, because still many medical oncologists prefer giving 6 cycles of chemotherapy, although we know that 4 cycles are as good as giving 6 cycles. After that, once the chemo part is over, suppose in the durvalumab in the EP arm, durvalumab maintenance was to be continued every 4 weekly till disease progression or unacceptable toxicity. In the EP arm, option of prophylactic cranial irradiation was given. The stratification was planned based on the platinum agent, that is carboplatin or cisplatin. The primary endpoint of the study was overall survival. Secondary endpoints were PFS, overall response rate, safety profile, and patient-reported outcomes. So, durvalumab 1500 milligram flat dose along with platinum etoposide 3 weekly for 4 cycles in the initial treatment phase, followed by durvalumab 1500 milligram flat dose every 4 weekly till disease progression as maintenance. Choice of platinum was allowed in the comparator as well as the durvalumab arm. Cisplatin and carbamazepine both were allowed, which is the real world practice. Overall survival was the primary endpoint. Control arm, in patients with control arm, 6 cycles of platinum doublet were allowed. Option of PCI was offered in the control arm in maintenance phase, but it was not given in the durvalumab arm. Asymptomatic as well as treated and stable brain mets patients were included in this trial. Especially coming to, as we all know, patients with having existing brain metastasis have a worse outcome compared to somebody who is not having brain metastasis. The CASPIAN study also had, if you see the exploratory endpoint, it also had OS and PFS analysis in patient with or without baseline brain metastasis. It was a pre-specified subgroup analysis in this trial, where durvalumab plus platinum doublet was found to show improvement in OS compared to etoposide platinum alone, regardless of presence of brain metastasis. As you can see the Kaplan-Meier curves, first on the left is the patients who have brain metastasis, and on the right is the group of patients who do not have brain metastasis. Although the number of patients with brain metastasis was quite less, it was 27-28 patients in both the arms, the overall survival was significant, and we can see the Kaplan-Meier curves clearly separating, even in patients who had brain metastasis. So there was a clear-cut benefit, and this was in the overall population as well. You can see there was benefit even at 1 year and also at follow-up at 18 months. So irrespective of the presence of brain metastasis, the durvalumab plus platinum doublet regime was working well, and there was benefit in overall survival. Also, the objective response rates were better, almost in the range of 70% compared to 60% in the platinum doublet arm. This is the updated 2-year survival in this CASPIAN study, where we can see there was an absolute difference of 8%. The Kaplan-Meier curve starts separating at around 6 months, and they do remain separated even at 2 years. So at 2 years, in the platinum doublet arm, there were 14% of the patients alive, while in the durvalumab plus platinum doublet arm, there were 22% of the patients alive. So there was an absolute benefit of 8% at 2 years by addition of durvalumab. Follow-up scan was done in February 21, which by the time patient had taken fractions of whole brain radiation therapy, 4 cycles of chemotherapy, and 3 doses of immunotherapy. And as we can see, there was a very good response in the primary as well in the brain metastatic lesion. Patient was continued on treatment. Patient did receive 6 cycles of chemotherapy, and patient was then on monthly immunotherapy durvalumab dose. And in December, follow-up PET scan was done, which was also showing disease in remission, both the primary lesion as well as the brain metastatic lesion. So to conclude, durvalumab plus etoposide platinum is the new standard of care in first-line extensive stage small cell lung cancer, based on the overall survival benefit in patients with and even without brain metastasis. Thank you.